everybody, and welcome to In Conversation. Our guest on today's episode is Dr. Lucy Andrews. Lucy, welcome to the podcast. It's wonderful to have you here with us today. I want to thank you for your time. And just to begin by asking, how are you and where are you calling in from?
Hi, thank you so much for inviting me to join this conversation. I'm really delighted to be invited to do so and to join you all. Yeah, I'm Lucy Andrews. I'm a GP and I'm in Wandsworth in London. I've been a GP since 1995 and a GP educator since 2011. I also work in child safeguarding and also training to be a family therapist, so have an interest in kind of family dynamics built into my practice as a GP.
Wonderful. Oh, well, thanks for telling us a bit about your role and your relationship to the healthcare profession. One thing I'm noticing from all of these podcasts is one job isn't enough for any of you healthcare professionals. You can be educators, academics, published authors. It amazes me how many different roles and different hats you all wear. So thank you, first and foremost. And I wanted to ask you a little bit today, though, about some of your personal interactions with the NHS. I think it's kind of always quite fascinating to have an insider's take, but from the perspective of almost like a patient or someone going through the system. Now, I know you've obviously been through this situation with your son recently and his health. I was wondering if you could perhaps tell us a bit about your story and then tell us a bit maybe about the questions that it led you to ask about the NHS and how maybe it kind of changed your perspectives a little bit.
Yeah, absolutely. Thank you. It's been a very interesting few months, really, and I think the backdrop to that is sort of the context of primary care and the current climate that the profession is in. And yes, I've raised 3 sons who are now young adults. My middle son, who's 20 and is very fit and well, active, in fact, training to be a personal trainer, presented in March with symptoms of lightheadedness and dizziness over about a 10-day period. And we took him to A&E actually because he was breathless at home. And he was admitted for 2 days, needed an iron infusion, and was found to be profoundly anemic. And whilst his care in that initial period was superb, subsequent to that, and that was now 4 months ago, he hasn't been seen in a face-to-face consultation at all, either by his GP or by any of the consultants in the secondary care setting in the hospital. So he has had a series of investigations about 2 to 3 weeks apart from each other. But the way he's heard about those have been through letters that have come through the post to him. And so about a month into this experience, I decided that I would send in an email request to the practice for somebody to make connection with him. And I did it in both my name and also his, so 2 separate requests. And the response to both those requests was that the situation was in hand in secondary care. And therefore for primary care didn't seem to feel they had a role in this. So this is in the context of it being a really good GP surgery we belong to. So it was disappointing. And I then, trying to be mum and also being a GP, it's a really hard situation to navigate. So after quite a lot of thought, 6 weeks in, I did email a local consultant who has been really great at getting the investigations through the system, but has still not seen him. So 4 months in, our 20-year-old, previously fit and well, who's not really able to travel or make any decisions about what next steps in life he might want to take, he's not really able to do so, and nobody has sort of taken care of that. So that's the situation. I think what was really interesting for me in this process as a GP, in the context of increasing electronic access to our services, was that I was disappointed that the surgery we belonged to were not sort of reading between the lines and seeing that a 20-year-old with a significant diagnosis didn't need a bit of care and hand-holding. But secondly, I saw the impact on my son, which was not articulated at home, but I could just see that the lack of contact was invalidating his illness. And this is somebody who sits in a medical family, so we were able to give him some sense of context and explanation, but but nobody from healthcare was feeling that that was a significant part of looking after him. So that's left me with lots of questions around, what happens to young doctors and their curiosity about what's happening to their patients. What does it take for a doctor to be interested in holding their patient's hand in today's medicine? And so that's what's sort of sitting with me still now. That's why I've come to raise it, maybe as a learning opportunity or a process for thoughts for reflection. I don't know where it sits, but that's the situation.
Okay. Well, Lucy, first and foremost, thank you so much for sharing that personal story. And of course, we wish you and your son and your family all the best and hope for a quick resolution to this issue. Yeah, really powerful to share such a personal anecdote, especially from someone inside the system, and for you to be so honest about that. Can I just begin maybe by asking, what do you personally think are the issues? What do you think are what's getting in the way of doctors having this curiosity, this humility, and these other sort of, I guess, facets that you see to be so important in a healthcare professional? What's your take on it?
I think doctors are increasingly being asked to tick boxes and being measured. Their performance, their skill set is being measured by things that are easily measurable. So that would be sending out an appointment in the right time frame, responding to a message in the right time frame, regardless of its content. So I think we're sort of closing down curiosity and creativity within medicine in that process. But I can't help but also think it must at some level be due to busyness, shortage of time, taking a shortcut where one can see one. You look in someone's notes and you see that someone has sent them an appointment for a scan, therefore they don't need anything else. I hope it's not a deficiency in training, but I do wonder, what the content of the training might be for some of the doctors who are finding themselves in this position and thinking that they're giving good care.
Thank you, Lucy. Yeah, that's really interesting too. I'm lucky to say that today we're joined again by my colleagues and intellect authors, Dr. Jens Foell and Dr. Rupal Shah. So I want to bring them in here too, because they're both practicing clinicians, GPs. Yeah, this seems to me like a recurring theme, isn't it? We've heard similar topics be discussed throughout the series of podcasts. What's your take on this?
A painful one.
Yeah.
Yes, indeed, because I can see clearly what the issue is from several sides. I think the issue is about parcels and pockets and mobilizing some special care, which is both a professional act, but also a personal act. And asking for this in a situation where resources are very scarce. I say a painful one because I know there's a complaint against me where a patient said, "Why haven't you done da 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 da?" And I thought, well, I've referred you urgently. I've done what I can. What else did you want? Because something happened. And she felt personally let down by me. Why haven't you done all these other things which I expected you to do? And I felt really painful. And I said, yes, I understand that you have this, that you complain. I haven't delivered what I would like to deliver. And I think I haven't delivered what I would deliver if I would be in different circumstances where I have more resources, more time, possibly a better sense where I can mobilize my imagination, my care, my extra bits for you right now. And obviously, maybe not an individual doctor, maybe the practice said, well, this is in secondary care. It's not our bit. We have to be more careful to protect our workforce. This is a young man. He's not end of life. He's not on the red list for deservedness and entitlement, etc. He doesn't need us now. And so you protect your work to rule. Probably right now with the BMA doing that is even more work to rule. You are in the system. It's not my job. But of course, on the other hand, I hear Lucy, the mum, Lucy, the insider saying, this is crazy stuff, my friend. This is a young man. This is not right. And it's a bit in the GP novel House of God when they say young enough to die. There's something wrong. Yes, it's not the usual group of old, vulnerable, etc., etc. Why do you not pick up on this little thing? Why are you not interested where something is wrong in somebody who is otherwise right? And that brings you right to NHS ethics, allocation resource, or attention to some things that may be easily fixed, and you are kicking it in the long grass in waiting times, and it's collusion of anonymity. It's somebody else's problem, hiding behind protocol, and it is extremely frustrating. And I see it from both angles. I see it as part of an organization where we say, oh yeah, we have to be tougher in bouncing stuff from secondary care and not doing this and not syringing ears and not cutting toenails and not doing this, not doing that. And that is a terrible injured place Lucy and I and Rue and so many other people are inhabiting at the moment.
Thank you, Jens. I appreciate that honest take on this too. Rue, I'd love to bring you in here, and I wanted to ask you kind of more specifically what you think the role of the GP is in all of this, but also just feel free to share your thoughts more generally as well.
Thank you. No, it's so interesting to listen to Lucy and to Jens. I completely get it because I'm in this world as well. There's numerous examples. We've just moved to total triage. So, for example, the other day, a 45-year-old man who unexpectedly had a first heart attack. The kind of label on the tin was, I want to be referred for cardiac rehabilitation and to see a GP. And so the response it could so easily be, let's just refer to cardiac rehabilitation, send some information, and then you kind of think, hang on, what is his experience of this? He's 45, he's had something very unexpected, he's got no risk factors that is life-changing. And, it's sad that the first response isn't, that is terrible. I wonder how he is, how he's feeling, how his family is feeling, what is my role in this? And I think that if, honestly, our role as GPs is just to kind of give information and make the referral, that is a very sad state of affairs. I don't believe that is our role. I think that, we must be able to have the imagination to try to engage with people's experience and not just to think that it's all about processing, about excluding red flags, about, pushing people on like it's a factory line. I think the reason to write this, the book, was to inquire about that. How can we bring meaning making into our role or bring it in, but kind of recapture it. I think it was always part of the role. When I trained, it didn't even need to say it. It was clearly there. So it's some more that it's being lost. And I think that is very problematic. Now I've sort of got a tiny glimpse of this and nothing like what happened to Lucy, but just recently I had a text from our GP about my daughter had a chest x-ray, and the text said, there are some abnormalities, please make a routine appointment. And the next appointment was 3 weeks, and I don't know anybody in the practice, and we're medical, we could access the x-ray report and it was all okay. But if I was just thinking, if I was a kind of lay person and had a text like that, I would, the next few weeks until I got the appointment would be horrific. Yeah, I think we have to kind of pay attention to all of that.
Jens, I know you wanted to ask a question relating to this. I'll bring you back in here, please.
Yes, and I think there are so many differences between practices where you can be very tight on protocol and foster this culture, or what we do in this practice, in our practice, to invite more personal text when you deal with results. I, for example, send many personal texts to people, which allow also to reply to me. I say but the downside is it is personal. I have to think about the patient. If I know the patient, it works well. It, I think, cuts a lot, and I say, hello, I'm here. In the same breath, we are sending condolence cards to patients. We are sending invites when something happened. So we are doing everything we can when there are biographical disruptions and some. So we take pastoral care serious. But on the other hand, we don't do industrial pastoral care, that we do that by default as kind of protocol with somebody sitting in a open plan office and writing this. Maybe that would be a good idea, but the only thing we can do is look at relationships, fostering continuity of care and fostering little acknowledgements, at least saying, I know this has happened, touch base if you want to. My role is to do that. And I see my role as pastoral care, being there when something happened, knowing it has health consequences. Maybe people don't want it, that's fine, but I'd like them to know that I'm there or we are there.
Lucy, that seems to connect quite a lot with this notion around humility as well. Can I bring you back in here? Do you have any comments to respond to Ru and Jens's take?
I don't think it's just about pastoral care, actually. It's something about the validation that he was quite unwell. And at the moment, up until this point, it really is only myself and my husband that have been sort of telling him that he has had quite a significant event. And not that we want his life to be weighed down by that, but if he had been invited in to have a conversation with a doctor who said, you know, we will get to the bottom of this and we'll keep searching, and if you get any other symptoms, please let us know, I think that would really help him feel that the situation was being held. So I think that the two areas of impact for him are either he doesn't care and he'll get on the plane and we might lose him to follow up, or the opposite, in that he's burdened by worry and concern. So I think that the reason that I feel that humility is important is there's something around the way we're interpreting these electronic total triage messages that leads us to put our own assumption on it very quickly. If we don't remain curious and have some sense of humility around what the patient is trying to tell us, we lose a sense of shared communication, and we're almost just rubber stamping it. We're just going through a protocol. It's almost a new skill, but we somehow have to learn how we tune into and listen to what the message is really saying. So, and I feel that requires, really nuanced, thoughtful care.
Okay, yeah, I think that I can see there's it's a difficult topic for sure. Jens, I want to bring you back in here as well, and I wanted us to also talk a little bit about maybe some solutions to I know, like, fighting for the soul. What are the potential solutions that you might have encountered as well? But Jens, I mean, I'll bring you back in here because I know you've probably got some other questions you probably want to respond to Lucy with.
Yes, and what I would like to bring in is risking more personal replies. That's my answer. But the risk is that I'm personally more exposed when I reply personally. With a complaint, for example, I would have liked to reply directly saying, sorry, I messed up. I was hungry, angry, late, and tired, or I could have done better. I'm a good person, but now I wasn't, or my actions were crap. I'm really sorry for that. But I couldn't. It had to go to the defense union, it has to be ironed out and had to be tight, and it becomes a different, more corporate reply. Maybe it's safer for me in my professional role, but maybe there's something lost in being personally available for people. I personally would like to have more personal and personal statement, personal replies. And that in the use of technology, I think we could use mobile phone and email and all these quick ways of communicating to reply quickly and be more personal, be present. And I would like this also for us as GPs to be present and not to be invisible and asking for more money. Of course, we need more support, but I think psychologically it's really difficult what we are doing as a profession at the moment. We are unattainable often, invisible often. The work we are doing is intangible. What we are paid for is a different entity from what we are doing. So I am really, really worried for the soul of general practice.
I completely agree with Jens about, in particular, I kind of purposefully send, these texts personally, and I don't use templates, and I, as far as possible, allow people the option to reply, is because I know that I might get it wrong, and there's a limit. Of course, there's a limit, and I'm not trying to virtue signal, but I think generic kind of text messages are problematic, and because it's difficult to interpret what someone really means. If you just get a kind of AccuRx template, a triage request, then I think we have to be mindful of checking that we've got the meaning. This sort of 45-year-old I mentioned may or may not want me to bear witness to what's happened and help him make meaning. But I think it's my duty to ask that question, and that we have to bring into conversation within the profession. That feels very important. I really get Jens as well about the corporate responses, and I see why we have to reply in that way. But I agree, sometimes you just want to say, that wasn't me at my best. I'm really sorry. It was a bit crap, wasn't it? I agree. I think we have to make sure that that patients can trust us, because if they can't trust us, then we have to kind of wonder what our role is. And it's very difficult to trust a system or a kind of practice when you don't know anybody individually, and you don't get the feeling that anyone's got your back or anyone's doing that kind of holding work that Lucy alluded to.
I'm just going to jump in quickly here with an American take. Obviously, I'm born in the UK and spent much of my time interacting with the NHS. And in recent years, I've been living in the United States and dealing with the American healthcare system, which, as we know, is very corporate and quite different. But you kind of, obviously you pay, if you have insurance, things you pay, a copay to have a face-to-face or a virtual interaction with a doctor. And, you can pay to have quite a lot of those if you need to. So you can pay to play sort of thing. But nevertheless, you don't get any of this personal follow-up care interaction, even though that you're paying a huge amount of money directly to the specific hospital or whatever, healthcare provider, whatever it might be. And there's countless times I've actually been misdiagnosed, and it's been maybe the radiology department that's come back, or the radiographist written to me directly or something like that. But it's just interesting. I just don't want this to seem like it's all an issue with the NHS, because you're paying all this money over here, and you don't get any of that human interaction. That's been my experience anyway. You don't get that sort of, you do very much feel like you're on the conveyor belt, which is not something I expected. That said, you want to go have an MRI, you can pay for it, and in 2 days' time you'll be in there and you have the MRI for your non-life-threatening condition or whatever it is, or non-life-changing condition. So it's very agile when it comes to things like that. But the follow-up care hasn't necessarily been personal or humanizing. In fact, I found it to be quite the opposite. And you may be paying, but you then have to spend as a patient, what I've been learning. And thankfully, my wife is dutifully teaching me some of the ways around the system. Is that you have to then do all this research on which doctors are actually any good, and all of this. And that's in your hands, which is a different issue in itself. And you all of a sudden have to become au fait with a lot of different medical terminology and with what's the ratings on this? And, we have in academia, rate my professor. Well, there's all of this for doctors too in the US. And sometimes I feel like it's a bit like an episode of The Simpsons, where you're going to visit the doctor who advertises, and it's like, hello everyone, kind of thing. And it's been quite an eye-opening experience. I don't mean to go on a tangent there, but it's just been interesting for me to you pay and invest, but it doesn't take you any closer to the human side of things, that's for sure. Lucy, I've gone on a rant there, but any thoughts from you?
Yeah, I think I was just thinking, I suppose my sort of summary of this is, if we want general practice in Britain to not be a dying art, which it really is, the benefits of having a GP that connects with the patient and cares for them. I feel that although there's lots of benefits to the technology and the total triage, that we therefore really do have to be careful how we're training our GPs to not lose them and to not lose the art. So we have to think about how we're asking people to interpret and read and care for the messages and care for patients as a result of that. And I do come back to the fact that, you have a 20-year-old admitted to hospital, previously fit and well, a brand new diagnosis. If a GP is not going to be interested in caring for that patient, what's happening? And that it's left me with that question. If in the old days he had booked an appointment and sat in front of the doctor, I think they would have been naturally curious and felt they'd wanted to help follow his story through. So I feel like that's sort of where I'm at with this, is how we teach and train and carry on embedding what's really at the heart of the work that we do.
What would have made you feel sort of acknowledged as a patient in the system?
It's simply my son getting a phone call from the GP saying, "Why don't you pop in and see me, and I'll just talk it through with you, and even just examine you." No one's done that, and helped him think about when he might need another blood test. None of that has happened. So it wouldn't have taken very much to have made it feel really different. Then even he would have then had somebody he could contact if he had further questions or was feeling lost to the system.
I like the idea that GPs are among the list of pigment makers, drywalling, marionette making, and kind of or thatching endangered crafts in a model village. Look, that is a GP. Interesting what they are doing.
I mean, that's a frightening comparison, but one that does make a lot of sense. Rue, any thoughts on that?
Just wanted to thank Lucy very much, because I think Lucy, very, very brave. I don't know if that's the right word of you to bring this into a public forum. So I just wanted to say thank you.
I'd like to say thank you so much, Lucy. And of course, we wish your son all the best with a rapid recovery. And a big thank you also to Jens and Rue for joining us today on another episode of the Fighting for the Soul of General Practice in Conversation joint podcast. Does anyone have any final thoughts before we close?
Thank you, Lucy.
Thank you very much for asking me to join you.
Thank you, everybody. We will see you next time.